Welcome to our podcast, The Better You Are, The Better You Are. Whether it is physically, mentally, or spiritually, when you know better, you can do better. And when you do better, you'll be better. On this podcast, we share knowledge, expertise, opinions, and experiences. All things that can help you to change the game. By the time we're done, it's hard for you not to be encouraged. So join us. The better you are, the better you are.
Well, Danyelle, can you tell us maybe some risk factors and then talk about screening options?
Right. So when we talk about, let's start with screening a little bit. So start with screening just a little bit because I think it's important. So 10 years ago, when we talked about screening for colon cancer, we would say the average age of screening would have been 50. Well, today that does not ring true. The average age in which we start colon cancer screening is 45. And that is because, as you said earlier, yes, the cases for colon cancer in the older population has decreased, but the incidence, the cases of incidence or new cases of colon cancer in the last decade has increased for those younger than the age of 50, right? So, we say, well, why is the older population theirs decreasing? They're thinking because they were getting screened. If polyps were there, they were able to remove them before they turned cancerous. A lot of factors played into that. But the incidence of those under the age of 50 has increased significantly, like 2% over the last 5 years. And if you think about how many people are in this country and 2%, that's a lot of people. So the recommended age for screening now is 45, right? It's 45. And there are various ways in which we screen for colon cancer. But I always say the gold standard for screening for colon cancer is a colonoscopy. And what happens in that process is the day prior to your exam, you're on clear liquids. You can have broth. They can't be red or purple. And you will do clears that day. Your prep will depend on the gastroenterologist or your colorectal surgeon. But typically, it's usually one or two. You're either going to get a gallon of something called Go Lightly, which is an oxymoron because you're not going to go lightly. Or now they have preps called like the Gatorade prep, where you would do like 4 Dodolax laxatives, 2 o'clock, and about 5 o'clock that evening, you would get a liter of Gatorade, Powerade, Crystal Light, can't be red or purple. And you'll put a small container of Mil-Lax in there, drink it down, start going to the restroom about 6 that evening. And 6 hours prior, you do another liter. The next day you would go in, you have to have somebody go with you. They will give you some nice twilight sedation. You don't really remember it. And they will take a visualization of your entire colon from your anus rectal area all the way to the cecum, to the end. And bring that scope back, look for polyps, look for masses. That's the gold standard because that's true visualization. And so that is the gold standard for colon cancer screening. There are other ways in which you can get screened. They're not my favorite, but they are acceptable means of colon cancer screening. They have the fecal occult testing. They have the FIT testing, and those are all with stools. There's no visualization. And then they have Cologuard. And Cologuard is interesting in that it has about a 94% sensitivity specificity. So what you do is they send a kit to your house. You're going to think you have an Amazon box with a gift. It's a gift, all right. You will put a stool sample in, and then you will mail that in, and it's a DNA PCR. So they look at the DNA and the fecal occult. That test is every 3-year test. The fecal occult or the FIT test is yearly, right? So those are considered yearly. If you do the fecal occult, that's a yearly screening. The FIT test, that's a yearly screening. The Cologuard is every 3 years. Those are stool tests. Okay, not visualization, those are stool tests. But for people who are low risk, those are considered acceptable tests for screening. And like I said, the Cologuard is more sensitive than just the Hemocolt or the FIT test, because it does look at the DNA as well as blood issues within the stool, but it's 3 years. It's not visualization. The other visualization testing would be, we talked about the colonoscopy. There's a CT colonography where you would do like a CT scan of sorts. You still have to do the full colon cleanse, and then they would do a CT. And if they visualize any type of polyps or inflammation or abnormality within that CT scan, then you would need to have a full colonoscopy. And that test is every 5 years. That is not one where the insurance companies favor. It's not considered the highest yield test. So in terms of visualization, that one I rarely even order. It used to be, people used to get flex SIGs, right? And so that would only look at the sigmoid part. It would look at the rectum and just the left side, the lower left side of your colon. It did not go all the way through. It did not go to the cecum, but people would do the flex SIGs. That used to be a big screening test too. And again, that was every 5 years. This is my philosophy. Those are considered screening tests that are acceptable by the American Cancer Society. Yes, they are. But for me, I tell people, if we do Cologuard, and you have to be a low risk patient, meaning no family history of colon cancer, no symptoms of colon cancer to even do the Cologuard. If we do that, say at 45, it's only good for 3 years. So at 48, come back around, you have to get a colonoscopy. My thing is that everybody at some point needs their entire colon visualized with the scope. Because the Cologuard, again, is 94%, but you got that 6%, false positives, false negatives. And I've had one patient who had a negative Cologuard, and the next year she was having some abnormal weight loss, had some blood, and it was colon cancer. And she had a negative Cologuard the year before. A negative one the year before. So yes, nothing's 100%, but that 6% window, I don't love it. I do not love it. I do not love it. But for those who are low risk, it is considered an acceptable screening test. You know, and patients say, well, which one do you prefer? I said, my preference is a colonoscopy, but I give you the whys as to why I prefer that. You make an informed choice. But I'm going to tell you, if you do the Cologuard, that next 3 years, you must get a full colonoscopy. So those are the screening tests in terms of that. And so from 45 to 75, if you're low risk, negative, we do a colonoscopy every 10, Cologuard every 3, blah, blah, blah. Usually at 75, though, they say after 75, you don't necessarily have to get a colonoscopy. You can look at that based upon risk factors and life expectancy, right? But if a person has polyps, if they have a family history of colon cancer, if they have any issues with their stool, I'm gonna tell my 75-year-old, you still need to get screened, right? And typically once you get to 86, they usually say, no, you don't have to get any more screening, right? So I have an 80-year-old mother. Her mother had colon cancer. She has polyps. I have polyps. So my 80-year-old mother, she's getting a colonoscopy because her risks are high and she has a long life expectancy. As far as I'm concerned, my grandmother lived to be 98 and a half. So we rolling with that.
Amen.
So, yeah. So we really do have to look and stratify, but I always say these are recommendations. We treat people. So in terms of risk factors, we have some risk factors that we can have impact on, and then we have some risk factors we can't have impact on, right? So risk factors which we can have preventable impact in health. So they're saying risk factors for colon cancer include obesity. They're saying that people who have type 2 diabetes has a higher risk. They're saying people who eat lots of red meat and processed meats because of the chemicals that are in there have a higher risk. They're saying that sometimes they're finding people who have vitamin deficiencies, even vitamin D, and not getting enough calcium. They're not sure, but they have seen when they're looking at longitudinal studies, these are people who are considered to have greater risk. And so can we do things that are preventable, that can prolong or impact our risk? Absolutely. We can focus on diet and exercise, trying to get as close to our normal BMI and be as healthy as we can. Do we have to consume a lot of red meats and processed meats? No, we don't. They're even saying eating all these meats that frying high temperatures, which release toxins sometimes. Do we have to do that? No, we don't. So we can make impact there. In terms of diabetes, we know, particularly with type 2, a lot of times it's diet and exercise and weight based. So if, again, focusing on healthy lifestyles makes a big difference. Now, there are some things that we can't impact, but we can be proactive in making sure that we are screened. And that's family history. We can't do that. Gender, we know men have a greater risk for colon cancer than women, though women, it's still very high in women. But we can't do anything about our gender. We can't do anything about our age, because we know it's more common in people over the age of 50, but that is changing as well. So the things that we don't have impact on, we want to be proactive. We want to get our screenings, because the thing is, if you get a colonoscopy and there's a polyp there, right? There are different types of polyps. We have adenopolyps, and then we have inflammatory polyps, right? Well, the adenopolyps can be, adeno, they can be tubular, they can be sessile, but those polyps are considered precancerous. The inflammatory polyps don't tend to be considered precancerous, but we still have to also look at the size of the polyp. So even if it comes back and they say, well, it's not an adeno where you have a greater risk of cancer, but that polyp was big. It was greater than a centimeter. Well, that's still a red flag where you may not be on a 10-year screening. You might be on a 5-year, right? If you have a colonoscopy and you have more than 3 polyps, that's a flag, right? That's more than 3 polyps. So that puts you at higher risk, even though those polyps were biopsied and removed. They were found to be non-cancerous, but you had more than 3. That is not going to be a 10-year screening for you. That's going to be a 5-year or a 3-year screening. So again, we have recommendations, but we treat patients, and we have to look at the big picture in terms of how we approach risk factors and screening.
I think that's good information to know. And what I like about it as well, your lifestyle, your things, the better you are, the better you are. So even with
your diet,
right, exercise, those things are hypertension and diabetes and,
smoking. I didn't even say smoking, smoking and alcohol. I forgot to say those. Those are all considered risk factors for colon cancer. People who smoke are at greater risk. People who drink. If a man drinks more than 2 drinks a day, and if a woman drinks more than 1 drink a day, guess what? Your risk factors are increased. So we can do things lifestyle-wise to decrease our risk for colon cancer. Amen. Yes, we can. Yes, we can.
And help us all the way around for
help
so
us all
many
the way
things.
Around.
Yeah.
Help us all the way around. I always say moderation is the key. It's not saying that you can't have a good steak here and there. It's not saying that you can't have a piece of cake, because we all can have those kind of things every once in a while. But moderation, and we are excessive in our lives. We want to upsize everything. And so we need to move. We need to eat more lean. If we're going to eat meat, we need protein, but lean, we need more roughage. We need more green
Right.
vegetables. We need fiber. We need smooth moves through our colon. I tell people all the time, we want a smooth move through our colon. Let's get our fiber in there. Let's drink water. I ask patients when they come in, how much water do you drink? You don't want to know. I do. I want to know how much water you drink because water is important. And particularly even with colon health, your stool will sit there in the colon and not move if there's no fluid to push it through. And then we end up with hard stools and tear. So there, diverticulitis, it's so many things. If you have diverticulosis, we need that smooth move so you don't get an infected colon and lose half your colon. So lifestyle is also important when we look at prevention of a lot of cancers. And we sometimes are our own worst enemy as to what we put in our bodies.
Amen. I agree. Did you have any thoughts or comments on that, Priscilla?
The one thing that I wanted to opine on is how we're actually seeing the younger generation being diagnosed with colon cancer. And from a personal perspective, I have a 29-year-old son who was most recently diagnosed with colon cancer. So a year and a half into my journey, I was just talking to him about some of the side effects of the chemo. I was really lucky not to have the more severe side effects of that. And I, just happened to say, oh, I'm having some constipation here after I had my chemo. And he said, oh, me too. And I said, so tell me a little bit more about it, just in terms of having just a general conversation. And I said, are you having any bleeding? Because you can have, as you said, Dr. Loveless, hemorrhoids that will you can confuse if you see that. And he said, yes. And I said, you are. And I said, what color is it? And I said, is it bright red, dark red? What's actually happening here? And I don't think that I waited for him to answer the question, because he had a colonoscopy 4 years ago and had some polyp. And that's, relatively young
Very.
at that age. And so I remembered that he had it at the same provider group that I had mine. And I got on the phone and said, my son is having some bleeding and um, we need to get him in. And so within 3 days, they got him, they got him in. And I think that's, because maybe I am a cancer patient. He had his colonoscopy with them. And lo and behold, I remember coming home, my husband asked, I was out and about, and he asked where I was because he'd gone with my son when he had his colonoscopy, and came back. He called, and I came in the house, and he was standing at the top of the stairs, and I could look in his face and see something was amiss. And he said, just come upstairs. And my son was in his room, and he said, they think it's cancer. And so I, listened to what they had to say. And I said, well, from my experience, um, it's something that you can handle. They will do the biopsy, but physicians can tell just based on what they're seeing, whether or not, and if they don't know, they'll tell you they don't know. And he did have it, and he had to go through 30 rounds of radiation, and I think 9 rounds of chemo. And so he is in remission at this point. Scans are clean, and he will have to have, the due diligence every 3 months for 2 years. And then I think every 6 months for 3 years after that, because, with colorectal, I think it's a 1 in 2 chance that it, may reappear. But getting the younger generation educated on what they need to look for, because their mind is on just straight ahead. and having them understand what the risk factors are. If you see this, then you need to say something. If you don't understand, you need to ask. And had not for just that general conversation, just think,
Just happenstance
Right.
conversation.
just
Yeah.
happenstance conversation. And from my experience, getting on the phone, because he
Amen.
didn't get on the phone, I
Amen.
got on the phone and called. Where would we have been?
Amen.
And so the question was, is this a genetic
Yeah.
flaw?
Right.
And I had the genetic testing and they said no, but my mom died of adenocarcinoma. And
So
so
that
here I am
so
with,
that's really interesting in terms of that, and kind of
Mhm.
circle back. So when we talk about genetics and colon cancer, there's something called familial polyposis, where
Right,
it's where you have a family where you history where you get multiple polyps, right? And
right,
typically with familial polyposis, we're not talking about more than three. It can be 100 to 1,000. And
hmm,
typically, by the time a person is 20 who has familial polyposis, they will have symptoms, right?
right,
Usually, by the time is 40, a lot of them have already had a partial or total colectomy in terms of the number of surgeries and in terms of prevention, right?
right.
There are some genetic tests that we offer, or with family history. So, like with your history, Priscilla, with the son, with your mom, yours, your son, definitely one of the first things that we would do is have you see a genetic counselor in
He
terms
did,
of
yes.
risk, yeah,
Hmm.
risk stratification,
And I did as well.
right.
Hmm.
But there are tests too, even that we offer in terms of in our office that as a primary care physician, we offer patients as options. Because for years, patients will come in and say, I just want my whole body scan from top to bottom. I want an MRI, CT scan. I want to be screened for cancer. Well, I'm like, really, we can't do that. We have to have indications for these tests, radiation costs,
Hmm.
etc. But now there are tests that we can offer patients who have a higher risk factor in terms of history testing that we can do. One is the Ambry test that we do. It could be through a swab, orally buccal swab, looking at DNA. I think it tests like 64 genes. And then
Right,
there's the
right.
Galleria test, which is a blood test that we offer patients, particularly those who have had a actual carcinoma or a strong family history. So we do have genetic testing, and some insurances will pay for it
Hmm.
100%. Others won't, but there are within the Ambry and with Galleria, I have pamphlets, in terms of those things here. A lot of times they have patient assistance. So those are options too that we can offer patients to get those type of screenings, particularly when there is a significant family history. Some people are like, I don't really want to go to a genetic counselor, but I say, well, at least can we start here um, in terms of offering some genetic assisting in terms of screening. So again, there are genetic predisposition to colon cancer. Yours were negative, but that history is still kind of
Still
concerning.
there.
Yeah, it's still
That's
there.
right.
It's
So
still concerning.
I had the consult. We both had the consult with the genetic counselor, and I was advised to uh for I course ask my sister and my brother, because we think about passing the genes down
Hmm.
through our children, but we forget about siblings as well. And so that was one of the things that was impressed upon me
Right, because
as
we usually
well.
say first degree relatives, right? And
That's
so
right.
that's mom and dad, and that's your SIBs. And
Hmm.
so, when we look at risk factors for cancer, that first degree relative is really important.
That's
And
right.
siblings are big ones that we have to also make sure that they get the proper screening as well.
That's right. That's right. So that's what I wanted to reinforce as well. The numbers for that particular age group in getting colon cancer are rising, and they don't know exactly, what's what, why is it happening? Some
And
is that they are unaware. The other, as we talked about, food. We don't cook like we used to. Everything is processed.
all
And
this
then
stuff
it's just
is
a different lifestyle.
absolutely. And so I am glad that you here was thinking like, wait a minute, this is not normal. And he had a colon. And so I think a lot of times people get a level of comfort if
Right.
they've had negative screening 4 years before, 3 years before. But you really do have to know that things can change in a year. That's why I tell women,
Right.
we do mammograms every year. Well, my mammogram was negative last year. I'm having family history of breast cancer, blah, blah, blah. I'm like, a lot can change in 1 year. Let's get our mammograms, right? And so
Right.
even though you had the negative colonoscopy, your body still can do what it does and things can change. And we still need to be in that mindset of let's check. Let's err on the side of caution.
Right. You don't want to take the time. You're thinking it won't, happen to me. And so, as a cancer survivor, people will say, you always get the question, where were you when got the news? And so that's one event, that I'll always remember. Where was I when I got the news, and how did I feel? Um, when I was told that I had cancer. And so, a year and a half in my journey, and I'm still going. Now I have to counsel my son in his journey. And so his oncologist, I will say this. When he had his initial consult with his oncologist, the family showed up. My husband, my other son, and we were sitting in the room. And the oncologist walked in, and she looked at me like, why are you here? She didn't make the connection with the last name. And I said, I'm his mom. And she was so stunned, and I think overwhelmed. She had an overwhelming moment that she said, would you excuse me for a minute? She had to walk out and compose herself, because now she's not only dealing with me, but she's dealing with my son. So she's dealing with a family, two people in one family. And how do you deal with that? And I will say she's done a fantastic job. And then the conversation to me was, remember, you are still going through your process. So you will have to, in taking care of him, remember to take time to take care of yourself. As you say, you put on that oxygen mask first, Lauren. You can't take care of somebody else unless you take care of yourself. So it was almost an hour conversation of reinforcement, admonition, encouragement, that this is where you are in your process. We're going to take care of your son. We're going to do the best that we can, but we need for you to do first things first. So that was the other takeaway.
I think it's a blessing and just great that you and your son have come through what you've gone through already.
Thank you for listening in today. Weren't you inspired, encouraged, and uplifted? We hope so, because we're praying the best for you. Join us again next time for more betterment, because the better you are, the better you are.